Good afternoon, everyone, and thank you for joining us for today's webinar. Our webinar today focuses on prenatal care and early entry into prenatal care programs at health centers. We are joined today by Luz Jimenez, who is the VP for Clinical Operations at Erie Family Health Center. My name is Rachel Logan, and I'll be moderating this session. I'm the Training and Technical Assistance Manager at the National Center for Health and Public Housing. At the National Center for Health and Public Housing, we offer training and technical assistance to health centers across the United States, and we focus on specific areas related to HRSA program requirements in the forms of webinars such as this assistance, monographs, toolkits, and other research-oriented services. After today's webinar, participants will be able to better understand the role of women's health promoters in helping patients to achieve early entry into prenatal care programs, discuss how to integrate WHPs and early prenatal education into the primary care setting, and also identify ways to manage and track obstetric patients throughout pregnancy. So our presenter today is from Erie Family Health Center, and she became the VP of Clinical Operations in 2007 and was promoted to Senior VP in February of 2013. Ms. Jimenez works to improve patient access to care as well as assure that patient medical visits are efficient and comprehensive as possible. Under her direction, Erie launched its electronic health record system, initiated pediatric and adult urgent care services, strengthened its referral process, maintained a patient satisfaction rate that exceeds 90%, and implemented emergency management procedures. Prior to her current role, Ms. Jimenez served as the Director of Health Center Operations at Erie's largest health center. In this capacity, she helped develop and expand Erie's women's health services into an extensive program that leads the nation on multiple quality measures. So very briefly, I'll cover facts related to prenatal care in the U.S. and at PHPC. So you see here that about a little less than 35,000 visits, patient visits for prenatal care or OBGYN care visits. And of those, the number of visits for PHPCs for perinatal conditions was 536. So PHPCs are seeing quite a few patients per year, but this number may be under what is actually occurring and may not represent the full extent of the services that health centers are offering to low-income and public housing residents. Also, there is a disparity between the percentage of mothers receiving late or no prenatal care and race and ethnicity. So American Indian and non-Hispanic blacks are more likely to enter prenatal care programs late or to not receive prenatal care services at all. Also, we understand that education plays a role into early initiation of prenatal care services and to utilizing those services. So it is important for us to be mindful of the health disparities that are present in prenatal care. And some of the barriers that our mothers face and public housing residents in particular are lack of transportation, money, insurance, and most of those common social determinants of health. And these are just a few resources that we compiled, but Ms. Jimenez will definitely cover a broad array of information as well. So I'll turn it over to you, Luz.
Thank you, Rachel. So good afternoon, everyone. It's a pleasure to be with you today to speak to the role of women's health promoters in the community health setting in particular, and the impact that our women's health promoters have had in helping Erie to achieve and sustain high rates of early entry into prenatal care. As Rachel stated, my objectives for our time together is to, one, discuss the role of the women's health promoters in achieving early entry into prenatal care. Two, to discuss the integration of women's health promoters and early prenatal education, which is a large focus for our women's health promoters here at Erie. And thirdly, to discuss the management and tracking of prenatal patients throughout their pregnancy, which is also a responsibility that our women's health promoters are tasked with, and have really benefited the way that we manage our OB caseload. Just to put the rest of the presentation into context, I'd like to tell you a little bit about Erie Family Health Center. We are located in Chicago. We currently have 12 clinical sites. As of July 2014, we will actually be expanding to 14 sites, extending into the northern suburbs of Waukegan and Mundelein in the Lake County area of Illinois. Of the 12 clinical sites, 5 of them are clinics located in area schools, 2 of which serve the surrounding communities in addition to the students of the schools where they are located. We have a freestanding adolescent center where confidential services are provided for any teen seeking STI testing or contraceptive services in a confidential way. And finally, we have 6 primary care centers staffed by family practitioners, internal medicine, OB/GYN, midwifery, advanced practice nurses, physician's assistants, pediatrics, and behavioral health. 3 of these sites also have dental centers. In 2013, we served over 52,000 patients, over approximately 153,000 visits. And our patient population is primarily Hispanic, 81%, with 55% of them being best served in Spanish. In order to ensure cultural competency, since most of our patients are Spanish speaking, our staff are also bilingual. So the providers that we hire, everyone from our call center operators who are the first point of contact, to front desk staff, to medical assistants, our case managers, and health educators, nurses, are all bilingual, speaking both Spanish and English. To give you an idea of the financial status of our patients, in last year, currently, our payer mix is about 26% uninsured, 67% Medicaid, 3% Medicare, and 4% commercial. Last year, 2013, we delivered 1,700 babies. And in terms of our quality outcomes, we've achieved rates of early entry into prenatal care between 85 and 91% over the past few years. Last year, we were at 87%. We've also sustained low birth weight rates. Last year, we were at 5.4%, where the Illinois state average was 8.2%, and nationally, it was 7.99%. Our breastfeeding rates at 6 months are currently at 30%. This is an area that we are focusing now. The state average, according to the CDC for Illinois, is actually 49.8%, and so we are doing some work internally to support our moms in breastfeeding. We are working with our partner hospitals who are seeking baby-friendly status, as well as providing breastfeeding support training to as many of our nurses, our case managers, and women's health educators as possible to provide both group breastfeeding classes within our health centers, but also one-on-one support during medical visits or as drop-in services. So to give you a little bit of background about the way that women's health promoters got their start at Erie, back in 2000, Erie began to expand its prenatal services, and we did so by contracting with OB/GYN providers through one of our partner hospitals. These additional 3 providers were added to an already existing midwifery practice at our largest site. At that time, our failure rate among prenatal patients was about 30%. So about 30% of patients who were scheduled for an initial OB visit were not coming. We had limited care coordination as it compares to today at Erie, and our early entry into prenatal care was about 77%, where the national average at the time was 83%. There was certainly a demand for prenatal services among the uninsured and underinsured population we served, as evidenced by the rapid growth of our services during that time. We added these 3 additional providers, and very quickly we were able to ramp those providers up because of the demand. And then given the high percentage of Hispanic clients that were best served in Spanish, we understood the need for culturally competent care and for providers and support staff who spoke Spanish. And so that was sort of the setting that we were in when we decided to launch the role of the women's health providers, or promoters here at Erie. So the women's health promoters were introduced a little bit later, around 2004, 2005. And our goal at that time was to primarily to assist pregnant women to establish early prenatal care by facilitating access and providing focused support. To me, this has been probably the most valuable role that they have played in helping us achieve early entry into prenatal care. They've provided a personal, sort of extended initial contact, establishing a relationship, if you will, right from the beginning, where the woman's pregnancy is confirmed at that initial visit, but also where the health promoter provides answers to their questions, aligns them with the right provider, and ensures a connection with other services that would help them to feel supported in getting the resources they need for good outcomes. We also began to see an improvement at that time in our no-show rates with the initial visit to the provider. So over time, our no-show rate actually improved from about 30% to under 15%. And I think this is in large part due to that initial extended time that the patient spent with the health promoters, where she is provided an opportunity to learn about our providers, about our services, but also to speak with someone about what to expect during the pregnancy and their feelings about the pregnancy. Another valuable role of the women's health provider has been to help identify early on those pregnant women who should be categorized as high risk. So there's an appropriate alignment early on with the right type of provider, as well as providing early referral to both social and clinical support services that she may need. During this initial visit with the women's health promoter, they are receiving early prenatal education. The women's health promoter is also able to centrally manage our patient panels by provider, which I will speak to a little bit further on. And then lastly, they are able to gather and record delivery data for future reporting. So who are the women's health promoters at Erie? Basically, it's anyone with an interest in women's health, with an ability to communicate in the patient's preferred language, someone who has the ability to conduct with training a basic health assessment, someone who is collaborative because they will be engaging with providers and with other healthcare team members to make sure that the patient is coming to her appointments and is following through, and that initially she gets the start that she needs in getting the services that we provide. It should be someone who is compassionate and non-judgmental, since they are going to encounter many patients who have challenging personal lives and circumstances that make it difficult for them to access health care, situations that they may be living in that require additional support services. And so there needs to be a sort of a compassionate, non-judgmental approach with the patient so that the patient feels free to divulge these things. Our first women's health promoter at Erie was a doula. She's still here in that role, but prior to coming to Erie, she was a doula, and so she had very relevant experience supporting and advocating for pregnant women, which is why we approached her in the first place. Some of our women's health promoters have a background in health education, and so they've worked at other locations or even within Erie providing some sort of health education and just have gravitated to that women's health promoter role because they have a particular interest in women's health issues. Some of our women's health promoters are nurses. Currently, some of our nurses at Erie do enjoy this aspect of the role, and so they collaborate with others, women's health promoters at their site potentially, and they do the verification of pregnancy and provide all of the same resources that our women's health promoters do. We've also had medical assistants. We have one in particular who used to work at our adolescent center for many years, supporting women's health providers there. And so a position opened up for a women's health promoter role at a site that we were opening, and she decided to apply for that, and she's done a fantastic job. If it's a medical assistant, really it just needs to be someone who is bright, who really, again, has that interest in learning and then just sharing what she's learned with her patients. We've had AmeriCorps workers also who have been at Erie, and when they're done with their service time, they've expressed an interest in staying on and working as women's health promoters, and that has been very successful as well. In terms of the integration of the women's health promoter into the larger team, it's important to note that the women's health promoter will be the first meaningful point of contact in our model of care. And so how they receive and engage with the patient can make a huge difference in determining whether that patient will follow through with the initial visit with the provider and whether or not they remain as a patient throughout the life of their pregnancy with our health center. We consider the women's health provider part of the larger prenatal care team, and as part of the team, they attend team meetings and they regularly collaborate with the providers on that team. Often we'll have a woman come in for a pregnancy test with multiple health conditions or multiple complex social factors that need to be discussed with a provider in order to determine the best course of action from the start. So they need to feel that they can do this easily by seeing themselves as an important member of the team and integral to the services that we're providing. And so we strive to do that. We want them to feel part of the team. And then using the right tools, a women's health promoter is an ideal person to, is in an ideal position to assign patients to the appropriate provider and therefore manage that provider's caseload to ensure that there's adequate access to appointments, first of all, but also that the provider has a reasonable number of expected deliveries assigned to him or her, and so can therefore manage their panel well. Women's health promoters can also follow up on patients that are transitioning to us from another provider. If they've learned that someone is coming from a different provider, they will request their medical information so that when the patient does come in for their first appointment, we have that information available to us. And again, they consult with providers as needed. Often at that very initial visit with the women's health promoter, something may come up, and the women's health promoter will go right to one of our OB providers or one of our midwives, discuss the patient with them, and make decisions about what the next steps should be. So these are the role and responsibilities of the women's health promoters at Erie. First of all, they are something that's been very successful for us is that we provide free pregnancy testing. So we advertised and offered free of charge the pregnancy test for the woman. They could walk in at any time. What we did is that we promoted these in community newspapers. We put flyers in the area. Where we had sites that are curbside, we would put posters on the entrances to our health centers so that women could see that they could come in and have a free pregnancy test any time of the day. The pregnancy test may be performed by the women's health promoter, or at some of our sites that are larger, the lab staff may perform the test and then notify the women's health promoter that the patient is there. Women with negative results are also referred to the women's health promoter, who will then sit with them, talk to them about why they thought they might be pregnant, determine whether they need gynae services, perhaps they are interested in getting birth control, or they're concerned that they've been trying to get pregnant and have not been able to do so, and want to be linked with a provider who could address that. So they start by performing an assessment. The pregnancy test is done. The patient is referred to the women's health promoter. She will bring them into a private space and talk to them about the feelings around the pregnancy and whether it was a planned pregnancy. Depending on the woman's response, she may offer options counseling to the patient. She will also take a social and family history, asking about the menstrual history, and determine then from the last menstrual period the estimated date of delivery. She'll record in our electronic medical record the height, weight of the patient. She will ask about any current medications and health conditions. She will also ask about smoking status, perform a depression screening by completing the patient health questionnaire, or PHQ-2. And all of that, again, is being entered into the electronic medical record for review by the patient's provider either before or at the time of the initial prenatal visit. A very important part of the women's health promoter role, of course, is the educational component. And so we've created at Erie a packet of materials that the women's health promoters provide to the patients at that initial verification of pregnancy. And these packets include a list of resources, but also very specific handouts covering what to expect during pregnancy at each trimester, warning signs of miscarriage so that they know when to call us at any time between the verification of pregnancy and that first prenatal visit. There is information on the benefits of breastfeeding. The women's health promoter will provide education on the importance of oral health during pregnancy and also provide a referral to Erie's dental centers. We have an initiative at Erie to better integrate our medical and dental services. So in addition to making the first prenatal appointment, the women's health promoters will also make a dental appointment for the patient at that verification of pregnancy. During that initial visit, we also provide a month's worth of free prenatal vitamins to all of our prenatal patients, and we know that it takes about a month for them to get the medical card here, and so that this just facilitates their getting started with the vitamins until they are covered for medication. The women's health promoter will also cover basic nutrition during counseling, and at that time they're also introduced to the option of centering pregnancy, which are group prenatal visits that we do here at Erie. And then, of course, if the patient is questioning whether to carry the pregnancy to term, the women's health promoters are equipped to offer options counseling. Administratively, the women's health promoter assigns the patient to a provider based on high-risk factors. So as they're doing their assessment with that patient, they are determining whether the patient would be most appropriately aligned with a certified nurse midwife or an OB-GYN doctor or a delivering FP. They track and manage the provider caseload, as I had mentioned, and I will be demonstrating in a few moments the tracking tool that we've created at Erie to do this. They'll, again, provide the referral for the dental care, so they will actually generate that referral enter the order into our EMR and then generate that referral for the patient. They'll give them the prenatal packet that they will take home with all of the resources. They will provide a referral to WIC. They will ensure that that patient gets to a case manager so that they are appropriately enrolled into a case management program. The case managers will follow them throughout the life of the pregnancy, and then once the baby is here, the infant is also followed for 12 months. And then they also will bring the patient to our patient benefits advocates, which is what we call our front desk staff, who are all trained to assist our patients with enrollment into Medicaid. This screen is just demonstrating our electronic medical record and one of the forms that is in an encounter type or visit type that is called verification of pregnancy. We actually created this content so that the women's health promoters have their own forms that they are completing, and then this gets integrated into the medical record, and the provider who is initially seeing that patient will be able to have access to this information. And so you can see that we will look at smoking status, exposure to smoke. They may do a pain assessment if that is appropriate. They will do the PHQ-2. And of course, they will take the menstrual history, and all of that is recorded here. So in terms of the process, just to give you an idea of what happens and how it starts and where it ends, any woman may walk into any of our sites where we offer these services, which is almost all of them. And again, the lab staff may perform the test, or the women's health promoter may perform the test. If the lab performs the test, the women's health promoter is notified, or if she is currently with a patient, we will offer to this new patient to have an appointment either later that day, or they may choose to wait, which is also fine, or they may choose to come the next day. We just want to be able to offer them the option. The women's health promoter notifies then the patient of the result of the pregnancy test once she has them in a private space. She begins her assessment and documentation in the EMR. She provides the education. She provides the vitamins. She makes that appointment for that initial OB visit, which is really important because the patient then leaves knowing when they will be coming back, and they've secured that appointment. She generates the referrals for oral health and any other sources that may be appropriate. She may complete a request of a release of information if the patient is transitioning to us from another provider. And then she will escort that patient once that whole process is complete. She will escort that patient to the case manager. The case manager does their own assessment, enrolls the patient into the case management program, and then the patient is escorted to the patient's benefits advocate who helps them with their MPE application. And then finally, especially if we have WIC services on site, which 2 of our sites do, they will be escorted to the WIC office so that they can initiate those services. And then on the day that the patient is due to come in for her NEOB appointment, the patient will receive an appointment reminder. This is also helpful for us in keeping our no-show rates under control. Our patients receive a call 48 hours in advance and then 24 hours in advance of their appointment. When the new OB patient arrives, the medical assistant does her intake, meaning she takes the vitals and enters the vitals into the electronic medical record. Our medical assistants use pre-visit guidelines for gestational age, and they actually use pre-visit guidelines for all of our patients. So there are certain tasks that they know that need to be completed. If there are tests that are appropriate at that stage of the pregnancy, they will also go ahead and initiate that. And then the provider, of course, comes in, does the exam. They may also do an ultrasound, We may do labs at the end of the visit. The case manager will see the patient at that initial OB visit. And then as the patient is leaving, she will schedule her appointment for her next OB visit with us. In terms of failed appointments, this is also a way that we make sure that we stay on top of following up with our patients who may not show up for an appointment. Our front desk staff, or PBA, Patient Benefits Advocates, sets the status of the appointment as failed if the patient does not show up. They then generate a no-show document in our electronic medical record, and they route that document to the women's health provider. The provider then enters follow-up instructions and routes that document to the case manager. In some instances, they may be a medical assistant working with the provider, asking them to contact that patient, find out why they didn't come to the appointment, see if there were any challenges or problems that created a barrier for them to come, and if possible, then reschedules that appointment for that patient. In terms of just to give you the full picture, in terms of delivery and postpartum care, we generate patient care summaries from our EMR. We send them to the hospital where the patient is expected to deliver at about 34 weeks. Our electronic medical record is also accessible to our OB providers from the hospital if for whatever reason they didn't receive the patient care summary. And then once mom has the baby, the newborn appointment is then made before discharge. And so our pediatrician who is rounding on the newborns will actually have the mom call us from the bedside and make sure that the newborn is scheduled for their initial appointment. Delivery data at some point is received from the hospital, and we track that delivery data, baby's birth weight, etc. And then, of course, the case manager then follows mom and the baby for 12 additional months. In terms of tracking our patients, or EDD tracking, our providers are impaneled based on their specialty, and their clinical FTE. And so we have a set number of, or targeted number of deliveries that our midwives will have per month, that our OB doctors have per month, and our delivering FPs will have per month. And so what the women's health promoter will do is, using a tracking tool, she will determine whether the patient should be assigned to a doctor or a mid-level provider based on the high or low risk status, and also, of course, taking into account the patient's preference. Some of our patients do come in and actually ask to be cared for by a midwife. They've perhaps done that for a previous pregnancy, or they'll ask specifically for an OB/GYN doctor, so we certainly want to take their preference into account. But we do have to assign the patient based on their high or low risk status. And so we use a tracking tool for this purpose as well. And then the women's health promoter will update the tracking tool to account for any patients that are lost to care, either because they've miscarried or for whatever reason they've decided that they're going to leave Erie and go to a different provider, or they're moving. All of that is tracked by the women's health promoter using this tool. This is a screenshot. It's not the full, unfortunately, this picture does not reflect the entire tool, but you can see here, if you look at the top left-hand corner of the screen, this is for the month of October of this year. And at the very top, what we have is our total capacity at the site that this particular screen represents. And so our total capacity based on the complement of providers that we have at this site is 111. So we can take 111 patients that we can manage given the number of providers that we have here, and based on their clinical FTE. And then the column to the right in green reflects, and this auto-calculates, and this is just how the tool was built by our fantastic QI department staff. It will show the number assigned to the site as a whole, but then also to the midwifery group, the CNM group, and the OB group. At this particular site, we have midwives and OB doctors. Then the list below that just shows a specialty group, and the name does not appear to the left on the screen, but these are the individual providers, and the tool reflects that individual provider's total capacity. So, for example, the first midwife can have 8 patients assigned to her based on her FTE per month, and currently she has 7 assigned. So we know that we can target that midwife if we get another walk-in, today who is seeking prenatal care. We can look to that midwife if that patient is low risk to take on 1 additional patient. Just to the right of that, you have the various providers' names, and of course we grade out the patients on this list, but we include their birth dates. They do have a patient ID in the electronic medical record if we want to put that ID here. We will add the enrollment date, and of course we will add their expected date of delivery, and then we have fields for any notes that are particular to this patient. And so we have built this tool by site. All of our sites manage their OB panels using this tracking mechanism, and it's worked actually very, very well. Any of our providers can access this tool at any time if they want to see the status of their panel. If a patient does fall out of care for any reason, for example, the women's health promoter may be notified by the midwife or OB provider that a patient has miscarried the pregnancy. And so the women's health promoter will come back into the tool and will indicate that, and that will open up an additional space for another patient. And so this is how we are managing our OB caseload month by month. At this particular site, it looks like we still have capacity for October. So just to summarize, women's health promoters at Erie have helped us to enhance our early entry into prenatal care by serving as the initial point of contact for pregnant women in our health centers. They have facilitated access and referrals to other critical social and healthcare resources. They are providing vital education and support, and they're assisting us in managing our provider panels and also in monitoring outcomes. So we have found women's health promoters to be a valuable asset. They've brought much benefit to the way that we've cared for our OB patients, and certainly make an impact, we believe, in keeping our, allowing moms to access our healthcare system early, but also in keeping them here and helping them to feel supported. And so with that, I want to thank everyone for listening, and I think at this point we open this up to questions.
Thank you so much, Ms. Jimenez, for your presentation on prenatal care. I know that prenatal care is just a huge issue that almost all health centers face, and learning how to manage the patients and working with your EHR and working with your staff is very crucial to all that. So I really appreciate the information that you provided. This is the time for question and answers, so if you would like to ask the presenter a question, please use your control panel to the right of the presentation and just type it into the box, and I'll read those off, and she is available to answer those questions. While I wait for questions to develop in the queue, I just have a few brief announcements to make. For more information on webinars, archived or upcoming webinars, as well as the other forms of training and technical assistance we offer, please check out our website at nchph.org, as well as consider joining a mailing list to receive updates and information about activities and what's happening. And also follow us on Twitter. So I tweeted out about this webinar and about Erie Family Health and how they joined us today. So follow us on social media. And we'll also have sessions such as this, but in workshops during our health symposium, which will be June 10th through 12th in Alexandria, Virginia. So we already have our registration site up. We are releasing the agenda and all those things, so check at our website for more information. Okay, and so we'll go ahead and open up the Q&A portion. So how do you utilize or include the community-based, faith-based, spiritual, and faith community nurses, lay health ministers, and advocates? Basically, how do you include the various stakeholders that come into prenatal care into your prenatal care plan?
When you say stakeholders, are you talking about other resources for the patient?
It seems like they're asking about community groups, so community-based, faith-based, and other lay ministers and health advocates. How do you engage those populations into prenatal care, outreach, and those kinds of things?
I mean, we certainly do partner a lot with community agencies and other resources that we look to enhance what is available to our prenatal patients. We do have a wide array of services at Erie that complement the full process of care for the pregnant mom, and so most of the resources that we're utilizing are internal. However, we will refer moms to external resources as well. I'm not sure if that's what the individual is asking.
That could be a possibility. So, I mean, another question was about how do you deal with prenatal patients that are at risk for like mental health and substance abuse issues. So maybe you can kind of reach those two separate ideas in the same answer.
I see. Certainly, part of our assessment at the initial verification of pregnancy, again, is whether or not that woman is high or low risk. And of course, anyone who is actively using or actively abusing substances would be someone that we would refer to external resources for that. Often it is to our the high-risk clinic at the hospital partner that we work with. We also do have internally behavioral health, a group of providers that we can engage. You mentioned substance abuse, but what was the other part of the question?
Or possibly mental health issues,
yes.
like depression, anxiety.
Right, and the response is the same. Depending on what it is, we may refer that woman to the high-risk clinic at the hospital. But much of that care we can provide internally.
Okay, excellent. Someone says that I understand that you reduced your no-show rate from 30% to 15%. Did you report the increase in early entry to care?
Did we report the increase?
Yeah, so was that information, I think, included in your no-show rate statistics?
Well, we saw that as our no-show rate decreased, our early entry rates actually increased over time as well. And so, we think that the women's health promoter had an impact by engaging that patient well enough at that initial visit that the patient actually did come in for her first prenatal appointment. And so the more that we utilized our women's health promoters at our sites, and we started with just one women's health promoter, and when we saw that it was working well, we decided to replicate that. And at our other larger sites, we began to implement that role. And now, every time we've launched a new site, we've actually made sure to include a women's health promoter as early on as possible if we're going to have OB services there.
Yeah. And then how do you train these individuals? Because they seem to come from different disciplines. So is there one set form of training that they receive?
We are getting to that. Again, you know, the first women's health promoter that we had was a doula in her previous life before Erie. And so she already had a strong foundation in this, but she worked very closely with a certified nurse midwife when we first implemented the role. And so that certified nurse midwife actually trained her, or refreshed her, if you will, on all of the assessment points, what we should be tracking, what we should be looking for, how that women's health promoter would determine whether that patient was high or low risk. And so it was somewhat informal. As the role has developed over time, currently my hope is that we will roll all women's health promoters under our health promotion department. Currently, the health promotion department is overseeing 2 health promoters that are focusing on women and prenatal care, but who also provide health education in other areas. So my hope is that all women's health promoters will be under the health promotion team so that they're receiving a standardized sort of training in this area. Currently, the women's health promoter at most of our sites are reporting directly to the site operations director. So I would like to change that.
Oh, okay. So that kind of moves us on then to the outcomes and the measures and evaluating the effectiveness of this. So how has, you know, the early entry rate improved since using or introducing this women's health promoter program?
So again, I think back in the year 2000 or 2001, before we had a women's health promoter in the role, our entry into prenatal, early entry into prenatal at that time was around 77%. Over time, we've been able to sustain the early entry above, you know, 85%. And so providing, again, the free pregnancy testing, offering that, a woman can walk in at any time during our hours of operations and ask for a free pregnancy test, and we will provide that. I think that's helped a great deal. We certainly saw initially, we actually advertised the service in the community newspaper, and we put flyers in the community, and we saw that women were actually coming as a result of advertising these free pregnancy tests.
Wow.
And so I think that has gone a long way. And where we have health centers where the entrance to the health center is at the curbside, we certainly put posters at our entrances advertising the free pregnancy test.
Excellent. Yeah, that's a very attractive feature to include. Do you also do outreach in apartment complexes or on site and out in the community, and particularly in underserved communities?
You know, where we have, I mean, some of our sites have existed for a very long time. In the last, 2 or 3 years, we've actually launched new sites. Where we've done that, we have done outreach in the community. And part of our outreach is going into schools and going into other social service agencies, introducing our services at Erie, and certainly communicating that we do free verifications of pregnancy and introducing the full array of OB services that we offer. And so yes, we do that, particularly when we've entered new communities.
Oh, okay, great. And you mentioned that you share data and information with some of the hospitals. Do you have like separate contracts, or how do you facilitate that information sharing?
Actually, what I spoke to was that we expect to get the delivery data from the hospital. And so, what we'd like to do is train our women's health promoters to enter that data into our EMR, so we have that available to us for future reporting needs. With some of our hospital partners, we do have access to their electronic medical record. And again, our OB providers can access our medical record from the hospital. So they have information readily available to them.
Okay, great. And speaking of, data and collecting information, do you use patient portals as a way to monitor or connect with prenatal patients, or do you use like telehealth or some type of technology to assist you?
Well, in the way of education, we do use Text for Baby. We try to get women engaged with that, again, at that initial verification of pregnancy, which many women really like that. Our patient portal, we just very recently launched in the last month. And so it's early on at this point. But yes, our intention is to communicate with all of our patients, really, but for our OB patients, certainly they'll be able to go into the portal, look up their lab results, and certainly send a message to their care team and receive messages from us. So we're looking forward to engaging our patients in that way more and more. But it is early. We've just launched it about a month ago.
Oh, okay. Very good. Very good. And you spoke of having a very large Hispanic population base, and have you developed any culturally competent education materials related to having a healthy pregnancy and some of the things that mothers need to be aware of that is relevant to the Hispanic population, or maybe in their language? Or
yeah. Absolutely. The prenatal packet that I spoke about earlier that we are now providing to our patients, all of our materials, really all of our educational materials, we make an effort to have available in Spanish. A lot of the handouts that are actually in our EMR, in the Electronic Medical Record Library, are also available in Spanish, and we can print those out for the patient. Our bigger challenge is that we have now expanded into areas in Chicago that are much more diverse, and so we're finding that we're needing to provide care in languages other than Spanish. We do use interpretation services that we access via over the phone, but we are currently, we have an initiative to try to align patients who speak a language other than Spanish with a provider at Erie, in the Erie universe, that speaks their language. And so our call center, for example, now has information about providers who may speak languages other than English and Spanish, and they'll also try to align the patients accordingly. But it's certainly something that we strive for. And yeah, certainly for the Spanish language, everything we have that we can provide in English, we will translate into Spanish.
Excellent. And for some of the different care models that you guys are using, do they include any group sessions or ways for pregnant mothers to kind of, congregate together and also learn from their peers?
Mm-hmm. So that we do that. We have centering pregnancy groups, and those have been especially successful at our adolescent center, probably because they're young, they're first-time moms, and there's something about experiencing the pregnancy with other young women feels really supportive to them. There's an opportunity to do a lot of education, and then because they're in a group setting, to hear questions from one another, and then toward the end of their time together, often the mom who has the baby will come back and bring that baby and share her birth experience with the other moms. So that's a model that we've tried to replicate to our other sites, but is particularly successful at our teen center.
Wow, that's very unique. And I think this is the last question in the queue. How has this program's cost, impacted your budget?
Yeah, that's a great question. Someone asked me recently if these visits by the women's health or to the women's health promoters are reimbursable. In the state of Illinois, they are not. But given the benefit that we see from having a women's health promoter to help us do the intake of OB patients and provide that initial prenatal education to make that strong contact right away early in the pregnancy, we really feel that this is something that we want to continue to invest in. And so, again, whenever we've opened 3 new sites in the last 2 years, and we're just determined to continue this model of care and pay for that particular position because we know the benefits that we've reaped from it.
Wonderful. Thank you.
Hopefully someday they will be reimbursable.
Yes, hopefully so you won't have to worry about that, those, changing rates and priorities. But even focusing then on that aspect, how has your outreach kind of changed, or has anything changed since the implementation of Affordable Care Act besides maybe seeing more patients?
Well, we are certainly doing a lot internally at Erie to educate our patients, first of all, who may be eligible for Medicaid or Medicaid expansion. We are doing a lot of outreach. We've actually had what we call Obamacare fairs at Erie, and those have been open to anyone from the community, whether or not they are a patient of Erie. And at those fairs, we've just provided a lot of education for patients who are trying to understand how the healthcare environment is changing, and we've taken the opportunity to help patients or existing patients, but potential patients as well, to enroll. So definitely doing a lot of work and a lot of outreach in that area.
Great. And actually we have one more question that just came in. Presumptive eligibility, tried Medicaid. Have you tried Medicaid?
Our front desk staff, or patient benefits advocates as we call them, are all able to assist moms or new moms or pregnant women to apply for Medicaid presumptive eligibility.
Yeah.
That happens at the time of the verification of pregnancy. So again, that's another huge benefit, that we try to walk the mom from the pregnancy test all the way through to the end, and so that by the time she leaves, she's enrolled in case management, she's received the referral for oral health care, and she's applied for Medicaid.
Yeah, very, very important and crucial to just overall prenatal care. Thank you so much, Ms. Jimenez, for joining us today and presenting this information and providing excellent answers to a lot of the questions that we all have with increasing the services we provide to moms, to women who want to be pregnant and who are pregnant, and making sure we encompass all of those aspects of a healthy pregnancy into our comprehensive services. And also, that we get reimbursed for it and all of those aspects. So I want to thank you. I want to thank our attendees and remind everyone that the slides and the resources will be made available after the webinar and also posted to our website. So I wish everyone a very good day, and thank you.
Thank you, Rachel.
All right, bye.
Thank you, everyone.